good afternoon. My name is Jenny Baumgartner, and it's my pleasure to welcome you to the NIH Office of Disease Prevention Scientific Interest Group webinar series. So the ODP Prevention SIG webinar series is designed to provide a space for the public to hear from prevention research experts and thought leaders who are making advances in public health. I will be the moderator for today's session. So today we're thrilled to have Dr. Jane Newberger from Boston Children's Hospital and Harvard Medical School, and Dr. Dongngan Truong from the University of Utah and Primary Children's Hospital. And they'll be presenting Update 2022, COVID-19, Multisystem Inflammatory Syndrome in Children and the Heart. Ms. Vicki Pemberton, Program Officer at NHLBI and Project Scientist for the Pediatric Health Network, will deliver a formal introduction of Dr. Newberger and Truong in just a minute. So before we get started with the presentation, I just want to go over a quick housekeeping. So I will go over some logistics here. All lines will be muted upon entry and will stay muted throughout the presentation. There will be a Q&A session at the end of the presentation, so please submit any questions to the Q&A pod as we've shown here. And please direct those to all panelists. You'll be able to use a chat pod for just general commentary and to request technical assistance. ODP staff will monitor these during the session. So while our guests are speaking, you'll be able to focus on them by going to the top of the page, pulling down the view menu and clicking hide non-video participants. Please note that the webinar will be recorded and posted to the ODP website and YouTube channel. So I know everyone's very excited for the presentation, so I'll go ahead and pass this to Ms. Vicki Pemberton to introduce our speakers.
So I feel very honored today to introduce the two speakers. Dr. Gene Newberger is a pediatric cardiologist at Boston Children's Hospital, where she has a very busy clinical practice. She sees patients with congenital and acquired heart disease. Her major research interests include clinical outcomes and neurodevelopment in congenital heart disease, Kawasaki disease, and Multisystem Inflammatory Syndrome in children, or Misc, which is the topic we'll talk about today. She is currently the cardiology lead for the CDC's Overcoming COVID-19 study. Today, she's joined by Dr. Dongngan Truong, who is an associate professor of pediatrics in the Division of Pediatric Cardiology at the University of Utah. Dr. Truong is the medical director of the Kawasaki and the Misc Clinic at the University of Utah. And together, Jane and Nan lead the NHLBI-supported Pediatric Heart Network's music study. We'll hear a little bit more about that today. So I think we're in for a really enlightening talk, and I'll turn it over to Jane and Nan.
Thank you very much, Vicki. It's a pleasure to speak today. These are our disclosures and conflicts of interest, but none are relevant to this talk. Our learning objectives are going to be to review the epidemiology of COVID-19 and Misc in children, to identify cardiovascular manifestations and management of Misc, to review the NHLBI music study, and then just a little bit at the end to update our current understanding of myocarditis that is related to COVID-19 vaccination. So as we delve into the topic of Misc today, it's good to note that history has really been shaped by many pandemics. This is an engraving by Lavasseur that shows the angel of death at the door during the 165 AD plague in Rome, and the culprit was thought to be smallpox. Much closer to the current era, the H1N1 influenza pandemic of 1918 affected 500 million people worldwide and killed up to 50 million victims. And interestingly, the mechanism was also thought to be cytokine storm. Moving to today, you see a world map of COVID-19, which began, as I think you all know, with a cluster of pneumonia in Wuhan City in December of 2019. As of January 7th, 2022, there had been 299 million cases, 5.5 million deaths, and on the viewpoint of hope, about 9 billion vaccine doses administered. Now, what is the burden of COVID-19 among children? As of the very end of December, there had been about 8 million positive US cases in children, but COVID-19 is much milder in kids than in adults. Children constitute about 17% of confirmed cases since the pandemic onset, about 18% of confirmed cases in the last week. Overall, the occurrence, COVID-19 has now occurred in over 10,000 cases out of every 100,000 children in the US population. Only between 0.1% and 1.6% of children are hospitalized, however, and very fortunately, in state-based data, mortality rate is just exceedingly low. So between 0% and less than 0.02%. We felt interested in what are the underlying medical conditions that are associated with severe COVID-19 illness in children. And this was outlined by Campanitas and colleagues. And what they found is a strong association between medical complexity and the risk of hospitalization or severe illness. So in your A panel, looking at hospitalization, compared to children with no chronic disease, those with non-complex chronic disease were about 3 times more likely to be hospitalized, and those with complex chronic disease almost 8 times more likely to be hospitalized. If you look at severity of illness, once a child is hospitalized, compared to individuals without known chronic disease, those with non-complex chronic disease were twice as likely to have severe illness, and those with complex chronic disease almost 3 times as likely. But our comfort that COVID-19 largely spared children was shattered in mid-April 2020 when we learned of extremely sick children with features of Kawasaki disease, shock, and cytokine storm, first from our colleagues in Bergamo, Italy, then London, and then the boroughs of New York City. And between April and May of 2020, a worldwide alert went out from health agencies internationally about this new multisystem inflammatory syndrome in children. The CDC's case definition for Misc includes age less than 21 years, a fever of at least 38 degrees for at least 24 hours, severe inflammation on laboratory testing. One needs to be hospitalized with at least 2 organs involved, to be positive for current or recent SARS-CoV-2 infection, and that can be by PCR, antibodies or antigens, or a history of COVID-19 exposure within the month before the onset of symptoms. And then very importantly, you can't have any plausible alternative explanation. One sees a pattern that is very consistent. This was first reported in London to show that if you look at the incidence of COVID-19, followed in blue, followed in red by the upswing in Misc, that one has a lag of about 1 month between COVID-19 and Misc. We see a very similar pattern in the United States, where you see data from the New York City state-based data. Again, the blue bars are COVID-19, the red bars are Misc, and in the overcoming COVID data, where COVID-19 cases are in cream, Misc in red. If we look at recent data from the CDC on the incidence of Misc, you see that there have been almost 6.5 million thousand cases of Misc and a low mortality rate of less than 1%. About 61% are male. 98% have had a positive laboratory test for COVID, for SARS-CoV-2. And about half of the cases happen between ages 5 and 13 years. You'll notice in the race ethnicity data that more than half of the children are either Hispanic Latino or Black non-Hispanic. So underrepresented minorities constitute the majority of cases. And so the question arises, are underrepresented minorities having more Misc because they also have more COVID? Or is it that you actually, even if you have COVID, are more susceptible? We know from this data by Payne et al. That appeared in JAMA Open, population incidence among children is about 5.1 per 1 million person months for COVID-19, and that the adjusted relative risk of having COVID-19 is way higher in Blacks and Hispanic Latinos, and a little bit so among Asian Pacific Islanders. On the other hand, if you adjust for having COVID-19, we know that about 3 out of every 10,000 children who have COVID-19 will develop Misc. And if you then look for the incidence among children with COVID-19 infections, you see a significantly higher adjusted relative risk for children who are Black and Hispanic Latino and also Asian Pacific Islander to get Misc among those with COVID-19. So what does Misc look like? The first large data came from the Overcoming COVID-19 study and was published in the New England Journal at the end of June of 2020, when we learned that a high proportion were treated with immunosuppressive or immunomodulatory drugs, including IVIG, steroids, IL-6 inhibitors in just 8%, anakinra in 13%, and then about half got systemic anticoagulation. 80% were treated in intensive care units, 4% had ECMO, 20% had mechanical ventilation, and 50% were on vasoactive support. But despite how sick these children were, the median days of hospitalization was only 7 days. We also learned from Dufort et al. From the New York State data that symptoms vary strongly according to age group. So, for example, Kawasaki disease is much more common among young children, and those symptoms appear very rarely in the teenage years, whereas myocarditis becomes increasingly common as you move to older ages. What about non-cardiovascular involvement? The most prominent symptom are gastrointestinal symptoms, happening in about 90% of kids across all ages. That's followed by hematologic symptoms, coagulopathy, and much more rarely, deep venous thromboses and pulmonary emboli. Mucocutaneous symptoms, as mentioned, are much more common in young children. Respiratory symptoms are also really common in Misc, which was initially a little bit surprising. So those respiratory symptoms don't help you distinguish very much between COVID-19 and Misc in children. Musculoskeletal symptoms and neurologic complications are fortunately much less common, but they do occur in Misc. The heart is very frequently involved in 80% of cases. So 50% of children have elevated troponin, indicating myocardial injury. 73% have a significantly elevated BNP level. About a third of children have depressed left ventricular ejection fraction or squeeze of the heart. In this series from Overcoming COVID-19, 8% had coronary aneurysms as defined by the American Heart Association's guidelines. And then ECMO was used, as mentioned, in 4% of children. So how does this actually occur? We know that cardiomyocyte invasion is really not a common feature, not a common factor in causing cardiac disease in Misc. But one does believe that there are factors like a dysregulated inflammatory system, endothelial injury and hypercoagulability, and microvascular injury all come into play. And these manifest with ventricular dysfunction, coronary artery dilation and aneurysms, and conduction system disturbances and arrhythmias. Now, it is interesting that among the many reports from across the globe on left ventricular dysfunction, that it is varied tremendously to as little as 20% to as high as 100%. And coronary artery dilation has varied in reports from as low as 6% to as high as about 26%. And this is because of selection bias in the various series and the lack of any standards across studies. None of these studies have had core labs, for example. But we also know from the Overcoming COVID data that Overcoming COVID-19, that if you look at the reports from echocardiogram labs, these are not core labs, but just echo reports, that no matter how bad your function is when you first come in, that whether you have severely depressed left ventricular function, moderately depressed function, or only mildly depressed function, that systolic function recovers very equivalently, and that most people are back to a normal squeeze of the heart by about a month, and in this series about 100% by 3 months. We know from very small series now, though, that diastolic dysfunction, which is the stiffness of the heart, is much slower to recover. This is a series from Children's Hospital of Philadelphia that studied 28 patients with Misc, 20 healthy controls, and 20 Kawasaki disease patients, and found that all of the Misc patients, even those who had normal systolic function, had diastolic dysfunction. That children who had myocardial injury as manifested by elevated troponin were more likely to be affected, and that diastolic dysfunction persisted even after normalization of systolic function. There was a very recent article that the same group has written that is just coming out that shows that by about 3 months, very few children have diastolic dysfunction. We also know that coronary arteries can be dilated in Misc. There's been some debate about whether there are true aneurysms that would involve destruction of the coronary artery wall, which is what we see in Kawasaki disease, versus just extreme vasodilation from cytokine storm that might leave you with an intact coronary wall. But giant aneurysms are reported. This is a case from Evelina, London. You can see the aorta, and then this giant aneurysm of the left anterior descending coronary in an 8-year-old boy. In the Overcoming COVID-19 study, again, only using the reports from echo labs, among 424 patients, 13.4% had coronary aneurysms defined by a Z-score of more than 2.5 or 2.5 standard deviations above expected for body size. But these largely also seem to get better with relatively sparse follow-up and without a core lab or any standardization. There are surprisingly few data on what the myocardium is like by cardiac MRI. This is, I think, the largest series to date. Only 20 patients studied by cardiac MRI 20 days later. Half of the patients had edema of the myocardium, so lots of fluid in the heart muscle. one of those 20 patients, or 5%, had a myocardial scar. Interestingly, the ejection fraction of the myocardium, of the left ventricle, and left ventricular strain, which is another measure of left ventricular function, didn't seem to correlate in this very small study with persistent myocardial edema, scarring, the age of the child, or even the timing of presentation. So larger series are needed. Arrhythmias and EKG changes have been reported in about 7 to 60% of patients with Misc. One can have very non-specific changes like we see in myocarditis with ST segment changes and prolonged QT intervals. Atrial arrhythmias have been reported with atrial ectopy or even atrial fibrillation. Ventricular arrhythmias, including ventricular premature beats, and both sustained and non-sustained ventricular tachycardia. And it's those ventricular tachycardia patients who are the most likely to require resuscitation and ECMO. And then finally, really interestingly, about 20% of children will develop heart block, and that can happen relatively later after hospitalization, first a long PR interval, and then sometimes higher grade block, again, likely reflective of myocarditis in these patients. So how do we manage patients with Misc? One of the best first studies was from the French consortium, where they studied 111 children with Misc and did a propensity score match. And among these children, they found that the primary outcome, which was treatment failure, defined by persistence of fever 2 days after introduction of the first-line therapy, was significantly better in children who received IVIG plus steroids compared to those with IVIG alone. They also found significantly better outcomes in the IVIG plus steroid group compared to IVIG alone with respect to the need for additional therapies after the first kind of therapy given, either IVIG plus steroids or IVIG alone, less need for hemodynamic support, a lower incidence of left ventricular dysfunction 2 days later, and a shorter stay in the cardiac intensive care unit. Following this article, there were back-to-back articles in the New England Journal of Medicine with different views. This was in the June 16th publication. Both of these were propensity-matched analyses comparing IVIG plus steroids to IVIG alone as initial therapy for Misc. In Sun et al.'s article from the Overcoming COVID-19 study, IVIG plus steroids as initial treatment on presentation or day 0 was associated with less cardiovascular dysfunction 2 or more days later, and also with less adjunctive therapies 1 or more days later in a composite primary outcome. The BATS, so-called BATS study, Best Available Therapy study by McArdle et al., which was done largely in Europe, found no evidence that recovery from Misc was different after primary treatment with IVIG alone, IVIG plus steroids, or with steroids alone. So why might that be? First of all, their inclusion criteria were different. The Overcoming COVID-19 participants were adjudicated and they met the CDC definition, whereas the BATS patients included suspected cases. Overcoming COVID-19 patients were a whole lot sicker on average, with half being on pressors, 40% having left ventricular dysfunction, and 18% being on ventilators. Compared to a relatively healthy BATS population. And then the outcomes were different. So the Overcoming COVID-19 study had a primary outcome of left ventricular dysfunction or shock, and the BATS patients had a composite of inotropic support or mechanical ventilation or death or reduction in disease severity score. So I think the answers as to the best therapy are still in. We're awaiting trials. There are variations in the guidelines from the American College of Rheumatology versus WHO, and they are constantly being revised. So we hope to get to more certainty in the near future. And I'm going to hand the podium over to my colleague, Dongngan Truong, who is going to begin the next part of this talk.
Okay, thanks, Jane. And so Dr. Newberger has talked about some of the treatments that we have for MIS-C with some data to support our treatment currently. But we now have some recent publications to suggest that we have ways of preventing the development of, preventing kids from having MIS-C. So this first study is out of France, which was a study of adolescents aged 12 to 18 years of age, so vaccine-eligible children, who had MIS-C between September and the end of October 2021. And their various analyses looked at those who were unvaccinated compared to those hospitalized with MIS-C that had at least one vaccine against COVID-19. They performed various sensitivity analysis in consideration that the adolescents were vaccinated at least 14, 28, and 42 days after the first vaccine dose to take into account timing of the vaccination and development of immunity, as well as the time between SARS-CoV-2 exposure and the development of MIS-C. And with each of their analyses, they found that having at least one dose of vaccine seemed to decrease the risk, of having MIS-C. And we have similar data from the US. Here, the CDC and the Overcoming COVID-19 Study Group performed a case control study to determine the odds of complete vaccination in the 12 to 18-year-old age group in kids that were hospitalized between July to early December 2021 for either MIS-C or hospitalized for other reasons, namely the two control groups, one of which was hospitalized with symptoms of SARS-CoV-2 but tested negative for SARS-CoV-2. And then the other control group consisted of children who had no symptoms of SARS-CoV-2. And when they looked at the MIS-C case patients compared to the controls, they found that most of the patients who had MIS-C had been unvaccinated, if you do the flip there of what's shown in the table, and compared to controls who had a much higher frequency of vaccination. And when they looked at vaccine effectiveness of two doses of the Pfizer vaccine, which is approved in the US for the 12 to 18-year age group, they found that being completely vaccinated had a vaccine effectiveness of 91% in preventing MIS-C. And so all very promising data that besides treatment, hopefully we can actually prevent kids from getting COVID-19 and developing MIS-C and preventing hospitalizations altogether. And so as cardiologists, one of the most common questions that we're asked with respect to kids and COVID-19 infection is when can they return to sports? And there are several return to play guidelines that have been released by both the American Academy of Pediatrics as well as the American College of Cardiology and other organizations. And things that are taken into account are the child's or adolescent's age and the severity of the COVID-19 infection to start with. And then, timing after suggested quarantines and full recovery of symptoms and fever. But overall, once kids return to play, graduated return to play over a couple of weeks is often recommended. And in kids who've had MIS-C, we felt that it's been reasonable to treat these patients as if they've had myocarditis. And so if there have been cardiac abnormalities, we've been restricting kids from, strenuous activities and sports for 3 to 6 months. And with resumption of activities, once cardiac testing has normalized, namely electrocardiograms, echocardiograms, Holter monitors or other ambulatory monitoring, cardiopulmonary exercise testing, cardiac MRIs. So seeing all those tests normalize and that recovery time period of 3 to 6 months will lead us to think that kids can get back to their sport and kids who have MISC. So there are still several things that we don't know about MISC in the heart. And, I think compared to when the pandemic started and we first started seeing MISC, we do know more. That being said, we only have limited data at this point on coronary aneurysms and cardiac dysfunction in kids with MISC using standardized assessments with core labs, namely echocardiographic and cardiac MRI core labs, as well as long-term outcomes in cardiac outcomes and non-cardiac outcomes in kids with MISC, and the association of these complications of the heart with clinical and lab risk factors and treatments. And so this is where NHLBI's Musc study comes in. And the Musc study stands for long-term outcomes after the multisystem inflammatory syndrome in children. And so the overarching goals of the Musc study are to characterize the occurrence and time course of cardiac outcomes, namely coronary abnormalities, ventricular dysfunction, and arrhythmias and conduction disturbances, as well as non-cardiac systemic organ dysfunction, the inflammatory response, and major medical events in patients with MISC. And we hope to develop clinical risk stratification models and to provide phenotyping for correlation with other basic and translational studies that look at mechanisms of the development of MISC. So the Musc study is an observational cohort study. And so essentially that means that there was no intervention for the study itself. We're observing these children over time. And however, there was research funding available for echocardiograms and cardiac MRIs if they weren't ordered by the primary provider as part of routine clinical care. And then as part of follow-up, we have up to 5 years of completion of annual medical history forms to assess sort of longer-term outcomes in these kids. And given that there's no special test to determine whether or not you have MISC or not, it's really a clinical diagnosis. We do have some cases being adjudicated by some of our colleagues within rheumatology, infectious disease, and cardiology. As many of us know, caring for these kids, sometimes the diagnosis can be difficult to determine, or it's not completely clear. However, to be enrolled in the study, patients did have to meet CDC criteria for MISC, and we had an initial goal enrollment of 600 participants. And participants could be enrolled anytime within the first year after MISC onset. However, patients could also be enrolled during the hospitalization prospectively, or they can be enrolled for those patients that were enrolled during the hospital course. We would reach out to them by mail-out cards, and after that, either phone, text, or email to discuss the study and determine if a patient was interested or not. And then we could obtain consent and assent either in person or virtually. However, given that, as Dr. Newberger had mentioned, many of the patients with MISC might be of underrepresented minorities and difficult socioeconomic stressors, might be difficult to reach or might be lost to follow-up. We did enact a waiver of consent for the collection of routine clinical data if we could not reach the patient or the family after 3 tries. And also, we thought it would be important to collect data on patients that we felt had MISC who died. And luckily, we felt that that would be a very rare event, but nonetheless, important data to collect. So here's just a map of the 33 music sites across the US, and we have Toronto in Canada as one of our sites. And so our primary outcomes are the worst ever left ventricular ejection fraction at 6 months, and the maximum Z-score of the proximal left anterior descending or right coronary artery by the 6-month visit. And we have numerous secondary cardiac outcomes, namely related to the coronary arteries, ventricular function, squeeze of the heart, valve function, pericardial effusions, the presence of arrhythmias or conduction system disturbances, and various MRI outcomes, namely things that Dr. Newberger had mentioned, such as scar, late gadolinium enhancement or scar formation on the heart, and evidence of edema, all findings of myocardial involvement. We also have numerous secondary non-cardiac outcomes related to the other organ systems of the body, lab markers of inflammation, admission to the intensive care unit, hospital length of stay, symptom duration, and major medical events such as having a stroke, the need for dialysis, plasma exchange, ECMO, which is extracorporeal membrane oxygenation, or heart-lung support, or ventricular assist devices in patients with very poor squeeze of the heart. Also mortality. And so here are just some examples from our case report data collection forms, looking at the various organ systems that we ask about at our annual visits. And you can see that they're pretty extensive. This is just the rheumatologic, asking the broad question of, has the participant been experiencing any of these general symptoms, and then diving deeper into particular symptoms and those that answer yes. Including medications that might be related to these various symptoms. And again, neurologic with the broad question of if the participant is experiencing any neurological symptoms, and then doing a deeper dive into specific symptoms if the initial answer was yes. And so our various core laboratories to do standardized assessments of the heart. So Kevin Friedman from Boston Children's Hospital directs our echo core lab. Our MRI core lab is directed by Michael Taylor of Cincinnati Children's and Andy Powell of Boston Children's. And our biorepository, because we do have the option, participants have the option of giving a blood or saliva sample for future genetic sequencing to look at potential genetic predisposition within MISC. We have Dr. Mark Russell from University of Michigan. So here's just a table of schedule of measurements to give everybody a sense of sort of the data that we're collecting and at what time points. So it's pretty extensive overall, medical histories, cardiac testing, and we're also assessing quality of life and global health using PROMIS tools. So our broad informed consent form that our participants sign allows us to share clinical and genetic data broadly, which is great to collaborate with other studies that are going on at MISC. And it also allows for review of the electronic health record. And something that we've trialed within the music study, which we think will really revolutionize potentially future research as well, is doing direct data pulls from electronic data warehouses, which many hospital systems have. So there are many benefits to doing direct data pulls, particularly for things like medications and labs. And we think that these direct pulls decrease coordinator burden, increase accuracy, especially for things like labs, and improve analytics. So working on this is Paul Avalach from Harvard Medical School and Boston Children's, who has been trialing this at Boston Children's Hospital and pulling their data. And we're soon to move on to Utah and our data warehouse here after checking for completeness of data collection, et cetera. And then once we've proven success at a couple of sites, we hope to roll this out music-wide at sites that have electronic data warehouses. So in terms of our enrollment, here's just a graph showing enrollment since we first had our first patient enrolled in end of September 2020. And in January of 2022, early January of this month, actually, we enrolled our 1,200th patient. And thus, at that point, we decided to stop enrollment. So we far exceeded our goals with lots of hard work from everybody. So in terms of our current population within the Musc study, you can see the breakdown of race and ethnicity, which overall is pretty similar to what we've seen in the CDC. So again, I think we're capturing a pretty similar population to what we're actually seeing in the community in terms of patients with MIS-C. 60% are male, and again, the school age group are the highest enrolled population, particularly in the 5 to 9-year-olds. We continue to collect data within our core labs with 280 biorepository samples, and our echo lab is feverishly reading all of the echoes for the study, and same with our cardiac MRI lab. So in summary, regarding the Musc study, we hope the Musc study will contribute important new information on acute cardiac findings and the long-term cardiac health of children with MIS-C, and facilitate surveillance for abnormalities in other systemic organs and overall well-being of these kids and adolescents. And we hope to provide a unique framework, including phenotyping for basic and translational research studies that might be occurring in MIS-C, and facilitate creation of a clinical care pathway for children with suspected or confirmed MIS-C. And so I want to speak briefly on RECOVER, which is NIH's initiative to study post-acute sequelae of COVID, of which MIS-C is a form. Now, there are 3 arms to RECOVER. One is the enrolling cohorts, the EHR and health system studies, and autopsy-based studies. And within RECOVER, the plan is to enroll thousands of children and adults across the country with post-acute sequelae of COVID. And so the Musc Consortium is proud to be a part of RECOVER to enroll children and adolescents with MIS-C into the pediatric cohort. And given similar objectives, in particular the better understanding of long-term outcomes in MIS-C and other forms of PASC, as well as risk factors for illness severity and timing of recovery, Musc and RECOVER are aligning to achieve these goals, and we're actively in the process of determining how best to interdigitate these 2 studies. There will be more to come in the future, and we're happy to be a part of this. And so shifting gears quickly to myocarditis, temporally related to COVID-19 vaccination, which is a pretty hot topic these days. And so all of us know that in May 2020, plans for Operation Warp Speed were first announced. In December 11th, 2020, the emergency use authorization for Pfizer-BioNTech, a COVID-19 mRNA vaccine, was approved for those 16 years of age and older. And that emergency use authorization for the 12 to 15-year-old age group was passed in May 10th of 2021. However, in April, we started to hear cases of myocarditis or heart inflammation in men less than 30 years of age following Pfizer's COVID-19 vaccine in Israel. And then we started to hear of these reports in the US as well, particularly in younger males within the military, reported by the Department of Defense. And in June, early June 2021, we had our first case report or case series of 7 adolescents who had myocarditis following COVID-19 vaccination. So since then, we do know a little bit more, although there's still a lot for us to learn. So what we know so far is that this heart inflammation tends to occur after mRNA vaccination. Patients who develop it tend to be male and typically occurs after the 2nd dose within 7 days of vaccination. And in terms of symptoms, the predominant symptom is chest pain, although many also report shortness of breath, palpitations, and fatigue. In a case series that Dr. Newburger and I gathered with 26 centers across the country and Toronto, of 139 teens and those less than 21 years of age with vaccine associated myocarditis. About 19% were in the intensive care unit. Less than 2% required vasoactive support. There was no ECMO use and no deaths. However, the majority had abnormalities on their electrocardiogram, namely ST changes, which we often see in pericarditis, which is inflammation of the sac surrounding the heart. Around 20% had decreased squeeze of the heart. And in those who had cardiac MRIs, 3/4 about had abnormalities, namely late gadolinium enhancement or that fibrosis or scarring, and nearly 3/4 had evidence of edema or excess fluid within the heart muscle. Hospital length of stays on average were pretty short, about 2 days and up to 10 days in our series. What we also know is that myocarditis seems to be a very rare event. So looking at VAERS data, and these data were presented at the ACIP COVID-19 vaccine safety updates. Actually, that's January 5th, 2022. So in terms of the reporting rates, the highest reporting rates of myocarditis per 1 million doses administered were in the 16 to 17-year-old age group of males, followed by the 12 to 15-year-old age group. Luckily, with data so far, myocarditis seems to be even rarer in the 5 to 11-year-old age group. And the same so far, again, very preliminary data that was presented on the 5th of January of booster-associated myocarditis. So in conclusion, nearly 2 years after the start of the pandemic, we know a little bit more about COVID-19 and MISC, namely incidence. Again, MISC is a pretty rare event. And we have some data on therapies to sort of support our treatments of IVIG and steroids, and also better understanding a bit of the short-term effects on the heart. However, we still don't know many things, namely risk factors for more severe disease, best therapies, and long-term outcomes. However, data so far suggests that vaccination does appear to prevent MISC in children. And myocarditis following COVID-19 vaccination is a rare event with the highest reported risk in teenage males. And overall, there seems to be a mild clinical course, although we do need longer-term outcomes data. So just a quick thank you to the music study leadership team. I've mentioned a lot of these people already, but lead coordinators David Garuba from Texas Children's and Tanya Morrison from CHOP, all of the support from NHLBI, Gail Pearson and Vicki Pemberton, and everybody at Health Corps, and in particular, all of the sites involved in music, including site PIs and the study coordinators, to far exceed our goal enrollment of 600 to enroll 1,200 patients. And we're happy to take any questions.
Wow, thank you so much, Dr. Newburger and Truong, for that wonderful overview. So let's go ahead and shift to the Q&A portion of our session today. Just as a reminder, as you see here, please submit your questions to the Q&A pod directed to all panelists. And I see that there's a number that have been popped in, so let me just go ahead and read them. So Sandy wants to know, are there studies that will be following these kids over time to determine whether they're highest risk for heart disease? So I know you mentioned your music study that's looking at these longitudinal effects and risk factors, but is there any other studies you might be able to refer Sandy to that are longitudinal in nature?
I think music is probably the one that will go the longest. I know Overcoming COVID, I think, has gone for 90 days. We are going to be following people for up to 5 years, possibly shorter if we find that everybody recovers very quickly. I'm not aware of any other very long-term studies, but that doesn't mean that there aren't any. There could be some in Europe, or ones that I don't know about. Nan, are you aware of any?
Not on a sort of broad multi-center type basis. I suspect we'll see single center studies looking at, single center outcomes, et cetera. But in terms of coordinated efforts among studies, I agree, haven't really heard too many others.
Got it. Thank you.
So
Liz, her question was essentially answered when you were talking about return to play. But she's specifically interested in screening of myocarditis as a result of COVID-19 infection. What's the latest on that?
Do you want me to answer that? Sure. So initially, the concern was that a fair number of even asymptomatic adults, at least with COVID-19 infection, had a fair amount of cardiac involvement. That being said, there have been subsequent follow-up studies to suggest that cardiac involvement is much less frequent than we thought initially. And so, the way the current guidelines are written, again, it takes into effect how sick the child was with COVID-19 to start. So if you were hospitalized, definitely if you were in the ICU, a much more cautious approach to return to play. But for the majority of kids who were treated as outpatients with pretty mild disease, currently, the screening involves, asking questions about chest pain, shortness of breath, etc., significant review of systems. And if any of those symptoms are positive, then referrals for testing such as ECGs, and again, depending on answers to the questions, potentially echocardiograms and potentially cardiac MRIs as well. But a lot of it is based on how sick the child was to begin with COVID-19. And then with return to sports, if there is development of any symptoms, that would also then prompt evaluation by cardiology.
Great, thank you.
Go
ahead.
I was going to say, I would just add that this is how hard you should screen elite athletes who've had COVID has been the subject of a lot of debate. But some form of myocarditis in some studies was about 2% out of 1,600 athletes, whereas others have shown rates of myocarditis as low as 0%. I think it continues to be a huge source of debate.
Thank you. So Sherry wants to know, what role does the primary care practitioner have after hospital discharge from Misc, and what should we be looking for?
I think most children with Misc will, in fact, I think all children with Misc will continue to be followed by a cardiologist, at least until one is sure that they're back to normal baseline by 6 weeks. And for those that had cardiac dysfunction, it'll be much longer. I think for the practicing pediatrician, and this might differ between Non and myself, providing some reality testing for families that these children are often, they may be tired, they may not be eating normally. Many of them are on immunomodulatory drugs when they're discharged that are being tapered. I think understanding, helping parents understand that it may be as long as 6 weeks, or we'll know with greater certainty from music that there's some time that will pass, and that most children aren't going to be completely back to themselves in a way that allows them to go back to full activities at school for possibly as long as 3 months and certainly 6 weeks. Non, what do you think?
I agree with everything you said, Jane, and also just sort of longer term, again, we don't know the long-term effects of MIS-C, so just sort of general screening at your annual visits as well, in terms of new symptoms that may have developed. I think the pandemic in general has affected the mental health of a lot of kids as well. And so I think that is a big place where I think, your pediatrician can help to navigate those sort of fields in terms of when assistance is needed. And luckily, so far, I think a lot of the children that I've seen with MIS-C have been doing okay long term, but again, just kind of general screening and, asking those questions.
Thank you. So the next question comes from Sandy. She is curious of how we distinguish between Kawasaki disease and MISC in children.
So
What's the
that is
distinction?
really, that is hard sometimes. As somebody who's spent many decades looking at Kawasaki patients, there are times that distinguishing somebody with Misc from a Kawasaki shock syndrome, or Kawasaki as we call those patients, can be really quite difficult. You can, if you have a history of COVID-19 in the previous, within 2 to 6 weeks, or you have evidence of antibodies or PCR or exposure, even if you look exactly like a Kawasaki disease patient or Kawasaki disease shock patient, that patient would still be classified as having Misc. Nan, do you want to add?
Yeah, I agree. It's so difficult to make that distinction. And in some ways, it is a bit of an academic distinction in the sense of treatment pathways are very similar. The only difference might be in sort of the longer term follow-up. And, for us, if there is, an exposure or, the possibility that it is MISC, we've tended to follow them a little bit longer than we would a typical Kawasaki disease patient who didn't have coronary artery involvement. And so, unfortunately, there's no diagnostic test really for either. It's really great history taking in terms of, potential exposures, et cetera. And I think things like antibodies have been becoming increasingly more difficult to interpret at this point in the pandemic, in terms of, looking at that epidemiological link to make the difference between KD and MISC. There are some differences though, kids with MISC tend to be older, that sort of thing. But again, if you meet criteria for Kawasaki disease, it's hard.
Got it. Thank you. So I can confirm the slides will be available. Feel free to reach out to us at ODP. We're happy to share those. We have 1 minute left. There's a lot of questions that people still, are seeking answers to. I'm afraid we're not going to get to all of them, but maybe I can see if we can squeeze in one more. Any data regarding recurrence of MISC and differences between long COVID and MISC in the time we have?
Misc is considered to be a form of long COVID, meaning that you still have symptoms of some kind more than a month after having COVID. Long COVID often doesn't present in a way most times of shock and extreme illness and need for hospitalization. But just is more likely to be exhaustion, sometimes lasting low-grade fevers, chest pain, headaches. And so that the presentation of Misc is that of an acute, severe illness, quite different from long COVID. We don't know the pathophysiology for sure of either of these, but they're likely to vary. My sense is that long COVID may last a lot longer for some patients than Misc, but we'll know that better from the Musc study. I can't remember the very first part of that first question.
Yeah, just if have you seen any occurrences of MISC? No.
Really great question. We get asked that all the time, that even when, so far, we have not seen one patient have Misc twice. Do you want to add to that, Nan?
I agree. I've not seen any, nor have I heard from colleagues that they've seen any. We have seen some kids with MISC get COVID again,
Yes.
but so far nobody has developed MISC.
Okay, we're 1 minute over. Thank you so much for sticking around and helping us to answer these questions. There's still more questions. I'm afraid we've run out of time though. Maybe we can see about getting those answered after the presentation. But before ending, I just want to quickly squeeze in here a big sense of gratitude to our presenters, Dr. Newberger and Dr. Truong, for all of the work you do in this area. There's a lot of gaps to be filled, and we're grateful that you've embarked on this research. So recording of this webinar will be shared at a later time. If you have any questions about the Prevention SIG webinar series, please reach out to me, Jenny Baumgartner. And again, I thank you all so much for attending and for your participation in this webinar. Thank you. Have a great afternoon.
Bye-bye.